presentations are recorded presentation, and Kish is sending his apologies for not being able to do a live presentation because he's in New York, and the time zone gap is big, so it's about 4 a.m. in the morning there. So the two presentations are pediatric demyelinating diseases, and the second presentation is the title has changed into neonatal metabolic disorders. Can we play the recordings, please? Thank you.
Mankad again, and the session is on pediatric inflammatory demyelinating disorders. The aim of this presentation is to make you aware of the recommendation changes as per McDonald's criteria for pediatric onset multiple sclerosis. And the key objective around that is to enable earlier and more precise diagnosis of pediatric onset multiple sclerosis in children, as well as making you aware of the rapidly expanding spectrum of relapsing demyelinating syndromes and how imaging phenotype can actually be used to distinguish one entity from the other. We also will be looking at some mimics to ensure that we don't over and underdiagnose demyelination and essentially forget other important mimics that one needs to be aware of. Our first cluster is exactly around one of these stories, which is going to provoke thinking and some lateralization of thought that will enable more effective diagnosis in times to come. The story is of a 5-year-old girl who presented in the year 2011 and the month December, which means pretty much 1 year after the 2010 revisions to the McDonald's criteria. Out here, you have a collection of axial T2s and a contrasted T1. I would like you to peruse the lesions and make up your mind as to what label on a radiology report should this patient receive. Are we going to leave it as non-specific lesions, or maybe consistent with inflammatory demyelination, or are we going to give a diagnosis of multiple sclerosis in a child who is 5 years of age? Now that we are in the year 2021, 10 years from that initial presentation. Whilst you're thinking, and whilst the clinicians were scratching their head, the child came back over the next few months again with further lesions, with some of the old ones going away, so there was a relapsing remitting pattern. Not much in the way of contrast enhancement at this point in time. And each time the child came, pulses of steroids were given. Over the next 5 years, she had multiple entries to the hospital, and I've put together a montage of the trajectory of her brain lesions over time. From the age of presentation of 5 years to the age of 10, this child has had multiple episodes to the hospital and multiple episodes of being given treatment without much effect. The question that begs, and this is for an MCQ Slido for you, is what is your diagnosis? Is this multiple sclerosis? Are we dealing with a spectrum of ADEM and then multiphasic ADEM? Or is this a mimic of multiple sclerosis like sarcoidosis because the age of presentation was quite atypical? Or is it something else like MOGAD, which is myelin oligodendrocyte glycoprotein associated disorder? Let's go back to having a look at the picture. Lesions relapsing and remitting over time, initially some of them showing enhancement, and over time, the brain atrophying away, with the lesions becoming coalescent, fusing with each other out there, and further atrophy out in the posterior fossa, as one can see. And the correct answer is multiple sclerosis. When we go back to this patient, it's all there in terms of evidence. Dissemination in time and place confirmed. Some lesions enhancing, some not enhancing. As per the McDonald's criteria, even from 2010, all other entities being excluded, particularly using a CSF and other biochemical and lab markers, they should have been given a diagnosis of multiple sclerosis even at the age of 5. However, the child came back with what was initially looking like an inflammatory and an active inflammatory disease, and then potentially into the spectrum of a neurodegenerative disorder. Not many conditions in medicine, if you think about it, follow this trajectory from being inflammatory to degenerative. I can only think of Alzheimer's disease as the analogous to this kind of presentation. It was only in the year 2016, the then standard for treatment being interferon, this child was started on interferons. The reality is, and this is actually learning from this case, that pediatric onset MS can happen earlier than the first decade of life or even the second decade. It can happen as young as around 4. And I think we may have even seen cases younger in some stray practices here and there. The other important message is that it has been proven many a times that early detection, early call on the imaging makes a definite positive impact to outcomes in terms of disability and the collective disability that happens over time. And therefore it goes back to the radiologist and us putting that important phrase that if demyelination is being considered, then the criteria as per McDonald's for multiple sclerosis have been satisfied. At the point of our report, we are not aware of what the CSF is doing. Is the child actively infected, or is there a family history of vasculitis? All those things are fine and they will be dealt with. But I think the radiological call of calling something MS is very important to steer management thinking in the right direction. The key message here is pediatric multiple sclerosis is a relapsing remitting disorder. Early diagnosis will guide effective and timely intervention with better outcomes. And that automatically brings us to the next revisions that happened in 2017, now 4 years ago, and how it enables better and quicker diagnosis. First of all, you can read the full text, but the key message there is clinically isolated syndromes, which are commonly seen, can also be given a tag of multiple sclerosis if the CSF shows specific oligoclonal bands. Second, we do not have to have only symptomatic lesions on the MRI to call them relevant. Symptomatic and asymptomatic lesions, wherever they are equally relevant. It could be brain or even in the spine, to confirm the dissemination in time and place. Thirdly, so third message for the pediatric neuroradiologist is that cortical and juxtacortical lesions can also be used for fulfilling these criteria. Cortical lesions are a new entity in terms of inclusion into MR criteria, which means that we should be adequately imaging these brains to pick up cortical lesions, as in we should be doing some volume flare sequences, and some centers have already instituted this. Finally, the increasing or decreasing T2 lesions are a marker of disease activity or not. We do not need to enhance every scan on follow-up to be able to determine activity. We should base that decision on the rising numbers and sizes of T2 hyperintense lesions, either on axial T2s or flare sequences, depending on whatever is most eloquent. So 4 key messages in terms of the 2017 revisions. Let's see how we can use it. More importantly, if you use it, you are going to make an impact. And this was proven even when the 2007 criteria were then revised in 2010. And this particular paper showed how survival as well as disability scores were impacted with early diagnosis. And the same thing would be happening in the context of the 2017 revisions. And there already is literature out there in terms of improved diagnostic outcomes. Not only that, it's important to remember that there is a difference in pediatric and adult onset MS, and the relapse rates are the ones that actually are significantly different. We see a lot more relapses in children. Cluster 2, 3-year-old, even younger child this time, presenting in the year 2007. So we're going back by a few more years this time, and this child was about to travel to Bangladesh and had some travel-related vaccination or immunization and presented encephalopathic, frank encephalopathy at presentation. The imaging is historic. We are even happy that we have some form of digital imaging from 2007. But it shows bilateral optic nerve swelling, there's optic neuritis, and it's quite long segment going all the way into the optic chiasm. There's some enhancement as well. And another fairly non-specific, the word non-specific we shall discuss later again, but fairly non-specific lesion out there sitting next to the frontal horn. Just the one lesion in the brain. And this child, in the view of encephalopathy, was given a diagnosis, and I'm sure you're thinking about it, of ADEM. And this was the year 2007, so they were given steroids, they improve, but then they come back in 2009 and they come back in 2010 with lesions that are relapsing, remitting in nature. And these relapsing, remitting lesions, therefore, were given a tag of multiple sclerosis because the year is 2010. We know that relapsing, remitting lesions happen in MS. We have excluded other possibilities. The McDonald's criteria is satisfied. Take a step back. Take a step back. Answer my question. What is your diagnosis? Is this multiple sclerosis? Is this the best example of multiple sclerosis you would put in terms of Dawson's fingers, periventricular white matter lesions? Or are we just dealing with an ADEM, MDEM spectrum? Or are we dealing with something like sarcoidosis? You see, the choices don't change with the scenarios. Your thinking will enable a more accurate and precise diagnosis. Or is this MOGAD, which is a myelin oligodendrocyte glycoprotein associated disease? And the answer here, if you have cast your vote already, is going to be MOGAD. And if you go back to this picture, this is where we are. The lesions do not look typical for multiple sclerosis. The lesions are subcortical white matter, and in fact, they can be frankly cortical as well. They are quite confluent, cloudy lesions, wisp-like lesions. Big lesion load in the posterior fossa in the cerebellopontine region, as well as the cerebellar peduncles, along with the fact that when you give contrast, you get not rings of demyelination kind of enhancement, but more nodular or micronodular or punctiform enhancement in these areas. This is indeed the spectrum of myelin oligodendrocyte glycoprotein, and the trajectory of this patient, if we go back to the patient, that's most important, is they were given steroids on a pulse basis for many years. Then they were instituted on interferons for multiple sclerosis, did not respond for 6 years. She was on interferon. This is big therapy. Only in the year 2016, IVIG, intravenous immunoglobulin, was initiated. And in her own words, when she comes back to the clinic, now she was quite young at 3, she presented in 2007. 9 years later, she's 12, she's able to speak better. She says to the doctor in the clinic, I have never felt so good in my life before. It took so many years to make a confirmed diagnosis and give targeted, precise therapy in terms of MOGAD, or myelin oligodendrocyte or MOG-associated disease. The key message before I show you more examples of MOGAD is that relapsing remitting patterns of multiple sclerosis should be discerned from a more umbrella pattern of a relapsing demyelinating syndrome. So everything that is relapsing remitting need not be MS. If it does not look like multiple sclerosis, it is generally not multiple sclerosis. And in that context, we have other disorders to consider. Keeping these ideas in mind, what we devised was a bit of an algorithm. And I'm going to give you the algorithm now and then come back to the cases in a moment. If a child presents with the first or subsequent episode of CNS demyelination, we do imaging of the brain and spine. This is important. Scan the full neuraxis, because in children, you get a lot more differentials. If it looks like MS, good enough to put in a book chapter with Dawson's fingers, periventricular lesions, and the diagnosis criteria for McDonald's are met, make a diagnosis of multiple sclerosis. If it does not look, and if it's got features of neuromyelitis optica spectrum disorders, you're going to think about 2 antibodies, either aquaporin 4, NMOSD, or you think about MOG, and you test for both. MOG-associated disease can have a more diverse imaging phenotype. We shall look at a few cases. If there are features of ADEM only at presentation, you should definitely look at the MOG antibody, because all the multiphasic ADEMs and the ADEMs that we see in children turned out to be MOG positive when we looked at a retrospective cohort. If it is negative, think about antibody negative relapsing demyelinating syndrome. It could be an alternative diagnosis, or it could be an undeciphered antibody at that point in time. And if your child relapses on monitoring, we pretty much go back to where we started. So it's important that these aspects have to be considered in the cases that we look at. A word on MOG using cases. Here is a set of 7 cases, and I hope you're seeing the screen not on your mobile phones, but on a proper computer, because I want you to focus on some of these cases. If you see a pattern where the lesions seem to be involving the deep gray structures, particularly the thalami, could be the basal ganglia as well as in case 5, and then over time they flip to involve the white matter. So it clears out from the gray, involves the white matter, and in a fairly symmetric fashion on the 2 sides. In fact, if I just gave you this case, you would probably start thinking about adrenoleukodystrophy. This is a leukodystrophy type of presentation. This is typical of MOG. MOG can also give you confluent white matter changes like that at presentation. It can also present with frank encephalitis. So have a low threshold to screen for MOG. We already have seen that MOG can involve the posterior fossa. It's a very pediatric specific entity. In adult post-mortem data, in around 20% of very frank multiple sclerosis, MOG expression was picked up even in the context of MS. So they can kind of coexist in adults. In children, we don't have that kind of data. But what is more important is that if you have a child presenting with ADEM, there's a pretty high chance they're going to be MOG positive compared to the adults. Once again, in the phenotype spectrum, we talked about posterior fossa lesions. The cerebellopontine angles are a very typical location where MOG can hit. And if you're not aware of this entity, you can misdiagnose these entities as encephalitis or infection or non-specific immune-mediated. But the one thing you're not going to call this is multiple sclerosis. The other factors that can present, as in this case, you've got rather confluent changes which look like an infective encephalitis. So you can have extensive white matter changes in the context of MOG, or you can also see these lesions which show punctiform nodular enhancement in the posterior fossa. This is a pattern of enhancement that is typical for MOG. Having talked about multiple sclerosis and MOG, we look into the next case, which is of a 20-month-old, this time even younger. And this child is presented with a history of dragging the right leg. And you can see why, because they have a lesion on the left side. Based on the CT scan, the child was given a diagnosis of stroke. Now, what is wrong in calling the stroke? Let's look at it. Let's let you think about it as well. If you have an infarct in that location without actually involving your basal ganglia, you can see the caudate is rather spared. Where is the infarct? If this is an infarct, it's completely in the white matter. It's a very atypical location for an infarct, but stroke being a clinical diagnosis, the clinical diagnosis would be that of a stroke, given the presentation of dragging the right leg and not using the right arm, etc. So CT confirmed stroke, and then the child had an MR and an MRA, which was done 3 days later. And in this context, what we are picking up is the lesion, shown again. Not much in the way of complete diffusion restriction, but you have a broken ring of restricted diffusion around the edge. Now that's pretty typical for a demyelination. This is a monofocal demyelination, not exactly an infarct. And in fact, there is another lesion out there in the right frontal white matter as well, also showing a bit of diffusion change around it. The vascular imaging did not show any narrowing or occlusion of the blood vessels. So we would make a diagnosis of a clinically isolated syndrome in this particular case. And what's coming up next is, what do you do next? In the context of a clinically isolated syndrome, are you going to give steroids, IVIG, which is immunoglobulins? Will you do a CSF? Or would you offer no treatment at this point in time, because most of them are going to be self-limiting anyways? And this is a question I pose to you, even though you are radiologists, because only when you know what's to be done will you make sense of the imaging and report it accurately? So wear your clinical hat and tell me what might be the next best step. There might be more than one correct answer here. The child has presented with signs. The child has a scan that is abnormal, but it's a unifocal or in fact bifocal lesion, still a clinically isolated syndrome. And the correct answer here is CSF, and the correct answer is based on, again, the 2017 revisions. I've shown you this slide, and the only point to note there was in clinically isolated syndrome. The moment you see this and you do a CSF examination, you should look for oligoclonal bands. Now, oligoclonal bands can be present in the blood as well as in the CSF, in which case they are called matched. You need unmatched or unpaired bands. That means bands should only be present in the CSF and not in the body. And if that is the case, then it would confirm a diagnosis of CNS demyelination, a very strong indicator that this patient has a high risk for multiple sclerosis. And in fact, if this presented in an adult, you would start them on first-line disease modification based on the 2017 revisions. In a child, clinically isolated syndrome is harder to treat. People would give steroids and the overall outcomes are good. Compared to that is this scenario. Now, this patient presented with headaches. They were scanned only for headaches. There was no encephalopathy. There was no fatigue and other things. It was completely a headache scan. And when you see lesions like this, which look like multiple sclerosis, it's a pretty good example of periventricular subcortical lesions, typically as you would describe in the context of multiple sclerosis. But all you have is headaches. This is a radiologically isolated syndrome. It's different from a clinically isolated syndrome. This is a radiologically isolated syndrome. And what you're going to do for this is only clinically monitor these patients. They may need repeat imaging at some point, but you're not going to start multiple sclerosis therapy, even though the phenotype matches. Okay, moving swiftly on to our next case. And in our next case is a patient who struggled to have the scan, hence the motion artifact on the imaging. And I think we have to live with motion artifact. We've got to see through it. So we have a 14-year-old girl with some red flags in the family, some consanguinity and an epilepsy happening in the father, presented with a massive sodium change and then this scan. And she was scanned because of her acute deterioration and diplopia with slurred speech. Now, the first diagnosis that comes to your mind is probably dealing with some kind of an osmotic shift, osmotic demyelination, and it can be pontine or extrapontine. So that's a fair thing to think about. The child undergoes a battery of investigations. The sodium, by the time the blood is done, has come back corrected at 150 millimoles per liter. And we have a slightly raised ESR situation here. The CSF has been done with a raised white cell count. So people are also thinking on the lines of infection in this particular case, but the initial infection screen, as you can see, is quite negative. So the initial diagnosis based on that was we can't completely exclude the fact that we might have corrected the sodium quite quickly, and we are dealing with a myelinosis situation, which also causes demyelination. Generally can happen in the pons, but can happen in other locations as well, in the periaqueductal region, as in this case we are showing here at this point in time. So nothing was actively done, but the child presented back in April of 2011, the same year. The previous changes were better, and this time she's got symmetrical disease involving the bilateral basal ganglia structures. And when you have that, you start thinking about bilaterally symmetrical disorders. You start thinking about mitochondrial because there was consanguinity in the family. There was epilepsy in the family, so maybe they have a predisposing genetic problem. And the child presented in this fashion with bilateral striatal changes. At which point the tests are all repeated. The CSF had oligoclonal bands present, and this was marked as false positive. The patient went on to have high-end genetic testing and biopsies for mitochondrial disorders. Nothing was found. At which point in time, I want you to think, where are we headed to? Because the radiologist is scratching their head, the clinicians are scratching their head. We've not come to the final diagnosis, and whilst we are still thinking the child continues to deteriorate quite a lot. And once the spinal imaging is made available to you in 2011, you can see the longitudinally extensive transverse myelitis. And this was 2011. At this point in time, we have to go back in history and think about why wasn't the aquaporin done initially? But there was nothing to go to check for aquaporin 4 at that point in time. Anyway, it was tested a few months later, came back as positive, and the final diagnosis was that of neuromyelitis optica, even though the child had not presented with optic neuritis. The child was commenced on targeted therapy with initial steroids and then steroid-sparing agents like azathioprine, remained relapse-free for 2 years. So if you look at aquaporin 4, the aquaporin 4 basically it's expressed in the brain. It's a transmembrane protein, and it is not very common in pediatrics in the first episode of demyelination. Of course, at this point in time, we screen people a lot more with these tests rather than sitting and waiting for disease to manifest itself, but it's not easily and commonly expressed. And the areas of expression of aquaporin 4 in the brain are shown in this beautiful illustration from this paper from yesteryears, which shows these paramedian areas, including the hypothalamic region, including the area postrema, but it's very paramedian to the brain where the aquaporin is actually quite massively expressed. Many a times you can see non-specific lesions, but you should look into these areas for the expression of aquaporin 4. And lesions in these areas typically would present with vomiting when the area postrema is involved, or even hyperphagia and emotional disorders with the hypothalamic involvement. Patients can be quite unwell and start gaining a lot of weight because of their hypothalamic involvement as well. So very important to be aware of where these antibodies and gene expressions happen. Now we've looked at two entities, myelin oligodendrocyte or MOGs, as well as aquaporin 4, both in the spectrum of NMOSD, but their radiological phenotype is quite different and distinct from each other. And disease restricted to the brainstem or hypothalamus is what you would see in aquaporin 4. Look at the area postrema. And what we saw in our cohort, that when you start seeing cerebellar peduncular involvement, we really only saw it in the MOG patients. So MS, MOG, and aquaporin 4, if you were to put it all in one place, this is what I want you to use in your practice. If you have lesions that are periventricular, deep white matter lesions, discrete lesions, typically looking like MS, you may have spinal cord lesions as well. And the spinal cord lesions are very commonly eccentric, but these lesions are not confluent. They are different and discrete lesions. This is multiple sclerosis on radiological phenotyping. Of course, you have to think about other things as well, like, what is the contrast doing, etc. If you have lesions, big lesion load here in the posterior fossa, the cerebellar peduncles are involved, you've got cortical, subcortical changes, punctiform enhancement, irregular enhancement, and on your cord, you've got longitudinally extensive disease, and it takes the central cord. And also, let me add here that the conus medullaris is typically involved. Think about MOG. Eventually, if you have a brain like that, where the child is presented with vomiting, you're not seeing much in the way of lesions, but you may have lesions involving the hypothalamus or even the area postrema, not clearly shown here. But you have a pretty large lesion load. You can have bubbly lesions in the spinal cord as well. You're going to call that aquaporin 4. Multiple sclerosis, MOG, and aquaporin 4. Cluster 5, as we move towards some stray realms here, is a caution. This is a 14-year-old boy who was previously well and presented with progressive lower limb weakness. And progressive weakness is a red flag sign. They had reduced walking tolerance. Other problems started, sensations being abnormal. The imaging was not very helpful initially. You've got brain and spine lesions, but the brain lesions don't look like aquaporin 4 or MOG or MS. The spine lesions are not really NMOSD-like. You've got patchy lesions, multiple levels of involvement. You've got a brainstem lesion out there as well. But if you make it harder, you can call it periventricular out there, subcortical out there. The lesions in the spine look more like multiple sclerosis. Lots of investigations done. The bands were positive. The bands were absent. So there was a primary CNS demyelination happening for sure. But the ACE is raised, the angiotensin converting enzyme. The Borrelia titers came back positive. The JCV was positive. But based on the Borrelia titers, a diagnosis of Lyme's disease was initially entertained. This was called Lyme's CNS neuroborreliosis. The patient was in London, and it is not uncommon now in parts of London to get neuroborreliosis. And we started opening our microbiology books to understand a bit about ixodes and the tick bites and how it happens in the different phases. The confirmatory test is Western blot, but it came back as negative in this particular case. And when you have a negative test, you can't make the diagnosis. And go back to the titers, they were actually quite low. So you can get a lot of false positives. The more you screen for, the more you're going to find on these tests. The child in the background is continued to deteriorate. Their walking tolerance is going down. Their fatigue is going up. They've had many doses of steroids, and people are struggling to figure out what's going on. Now, one of the antibodies, which I did not tell you about so far, is going to come up shortly in discussion. But at this point, considering that particular antibody, people went on to do a full body imaging, including a PET scan, CT chest, and people were looking for masses elsewhere. Could this be a paraneoplastic phenomenon, or is this some kind of an associated disorder? Then the child goes on to have further clinical deterioration. And you can read the slide, you can see that they've got new mild weakness in the left upper limb. At this point in time, we're seeing more spinal lesions as well. We're seeing these lesions looking fairly symmetrical. People started thinking again about metabolic and mitochondrial entities. Not much else happening out there in the supratentorial compartment, apart from some stray subcortical lesions. At this point in time, the diagnosis is unclear. A good few years have gone by. The patient has had IVMP, which is methylprednisolone. They were given a trial of interferons at that point in time, but couldn't tolerate it because of needle phobia, which was very common in the interferon phase that we were talking about, and was basically being managed symptomatically for spasticity and things like that. At this point, they had an antibody test for NMDAR, and it turned out to be positive. Now, interestingly, as soon as an antibody test comes positive, people start treating the patient for it. Except that after many years, this child only showed progressive disease. So if you go back to the imaging on this patient, if you think about the scans that we just saw, the spinal lesions kept increasing over time. The brain lesions were not completely going away. They were atypical, but they would be consistent with relapsing remitting multiple sclerosis. This was not what we would expect with NMDAR. NMDAR typically presents with movement disorders. NMDAR is a surface antigen, something to definitely consider, but the imaging phenotype is quite distinct for NMDAR. It's not an instant mimic of multiple sclerosis, as in this case, but you can throw antibodies through any of these neuronal surface antigens, but not all of them could be significant to the patient. Typically what happens is a viral prodrome, and these viruses can attack the neuronal surface. And when they attack this, they denude or kind of make these antibodies exposed to these receptors exposed to antigens, and they interact to create antibodies and antibody-mediated para-infectious phenomenon. But NMDA is to be alerted about. You're going to pick up lesions in the medial temporal areas. You may get brainstem. You may even get basal ganglia regions. And sometimes in the context of NMDAR, you can get lesions that mimic adrenal leukodystrophy, but none of these look like the multiple sclerosis that we were trying to look at just before this. So it's quite a diverse spectrum in NMDA. The other thing to remember about NMDA is that whenever a child presents with herpes simplex encephalitis, like in this particular case where they had HSV involving the left temporal lobe and spreading to the rest of the brain, then kind of leading to hemorrhagic necrosis in these areas. And this child presents 2 or 3 months later with a brain looking like this, with a very strong new movement disorder. And the clinicians know that this is going to be a triggering of the NMDA in the context of herpes simplex encephalitis, as shown in this paper of a cluster of 43 cases. So these viruses tend to attack the neuronal surface. they can denude the receptors, the large receptors sitting there, and antibodies could be generated against those receptors, and that could trigger the encephalitic or the immune-mediated encephalitic process, as we say. So over the years, we will be picking up many random, the more we look for we will be picking up many random antibodies targeted to specific receptors in the context of post-infectious phenomenon. And that's, again, a picture of things that you can expect for people to talk about, like LGI or GAD antibodies or VJKC. And not all of it is relevant, but it's definitely important to remember that the imaging could be not quite specific and could be quite diverse. But in our case that was positive on an MDAR, it's important to remember that these tests can come back positive even when the diagnosis is something else. There is quite an interplay happening in the background. And sometimes, of course, you can be left with a situation like in this case of a 13-year-old with acute onset of occipital headaches. So acute onset occipital headaches, none of these demyelinating syndromes gave you any acute onset of problems. But this was the picture, and this was the year 2010, and July and December shown out there. And this was given label of a hemorrhagic demyelination based on the fact that they had one brain lesion out there and a cord lesion which was over at least 3 contiguous vertebral levels with frank hemorrhagic changes happening. In December, the hemorrhages subside, leaving hemosiderin staining, some atrophy and gliosis of the cord. Now, what is wrong in labeling this as hemorrhagic demyelination? Think about it. Hemorrhage in demyelination has probably been reported in MOG. It's not commonly seen. Hemorrhage in the cord can happen in infective viral hemorrhagic fevers, but not in the context of demyelination. There's something we are missing here. And if you have an acute onset occipital headache kind of situation here, this patient should not have had all these tests with the false positive results. What they really deserved was an angiogram that was done only 6 months later, and that picked up an AVM in the spine. So sometimes you have to be very careful about the history that is being presented to you and then match it to the radiological phenotype. A spinal AVM that was treated, but it was misdiagnosed for a good few months. It is rare. It can cause pain and progressive myelopathy, but you have to be worried about acute onset and hemorrhage in these contexts. And my final case and a final warning to you is this patient who was sent to us with a tag of demyelination. There are lesions. The lesions are bilateral. Please look at the images because there's a question to follow this. Some of these lesions are showing enhancement, and I've thrown a bit of diffusion related changes also in some of these more active lesions. So when you have that picture, based on what we have learned so far, you're going to tell me whether this is MS-MOGAD aquaporin 4 diffuse glioma or a non-specific encephalitis. I would discourage you from using the term non-specific at all in your reports because the clinicians do not understand what non-specific means. They think we don't know what we're talking about, and probably that's true as well. But try to discourage yourselves. Next time you're going to put non-specific on your report, think twice as to what its impact and influence is going to be at the other end. The answer in this case is of a diffuse glioma. I'm going to go back to that case. When you have a picture like this, you're still going to consider encephalitis and do all the tests, treat the patient with steroids or whatever has to be given in the acute phase, IVIG. In fact, we all thought this was a MOG-related disease, but eventually a biopsy was needed. In the short-term follow-up, the patient was actually completely worsening, and the biopsy confirmed histone-mutated diffuse midline glioma in this particular case. My summary, therefore, is the fact that demyelinating conditions are diverse and the mimics are also diverse. It's important for us to again put, and I keep going back to wanting us all to become clinical first, radiologists next. It's important to be mindful of the laboratory findings and any red flags to actually make sense and put the jigsaw together. At the end of the day, we are working on these cases together, and you can see from the cases I've shown, a very good few years passed by before getting a precise diagnosis. So we are far from the reality of precision medicine if we are going to be non-specific all the time. I thank you for your attention. We do a lot of education and sharing information on Twitter as well, so please do connect, and I hope